set that just came out, so that might be helpful for people to go back and review.
Yeah, awesome.
In the future too. So, all right, well, good. Do you want me to go ahead and get started then?
Yes, please.
Okay. Well, good. Well, thanks for having me. I was asked to come talk about tube feeding and TPNs. So my idea was to kind of give you a bit of background about, usually what I like to do is talk about RDs for a couple of minutes, just where we come from, what we do, just to get our background, and then we can kind of dive into the tube feeding and TPNs. And then also, I'm always free to answer questions and stuff too as we go. So if there's something you need, let me know as we go along. And I'm feel free to happy to clarify something or answer some questions, and hopefully we'll have some questions at the end too for you about certain situations or whatever. But just in general, registered dietitians, they go through the 4-year BS degree. Soon in the next year or two, it's going to be required for a master's for all dietitians. So you're going to have to get masters. You do your internship after you graduate. So like usually every year we have at least 3 MSU interns here at Sparrow. You might see them around with us helping out. And they basically do a little of everything: clinical, food service, community, go out, maybe WIC and things like that. So they learn a little bit about everything. Then you pass your registration exam to become an RD, registered dietitian or registered dietitian nutritionist. That's kind of what they're calling the newer thing. And then you complete 75 continuing eds every 5 years. Then there's a bunch of specializations, like myself. I have a CNSC, so that's probably why I'm here talking about tube feeding and TPN, but that's all about nutrition support. Physicians, dietitians, nurses, pharmacists, those 4 fields can take this exam if they're really into nutrition support. If you go to bigger academic ones like U of M and stuff, some of them have nutrition support teams that they consult the nutrition support team for the tube feedings and TPNs. And so there may be pharmacists that do some of the tube feedings or TPNs there too, just to kind of give you an idea. But those 4 area specialties can take this exam. It's like a 250 question exam, board exam every 5 years, all about tube feeding, TPN, critical care type stuff. So if anybody's interested down the road or look from the future, if you're going into critical care, that's something that can kind of give you, just the nutrition side of it. Dr. Mosier's been talking about, if you're from MSU surgery trauma, he's been thinking about doing it for a few years. We're trying to get him to do it. There's about 3 or 4 dietitians here in the hospital that have it. I think we're the only ones out of all those groups. So there's no nurses, pharmacists, or physicians that I'm aware of yet that have done that.
Which is probably the people who are covering the ICU, like yourself and Amy.
Yep. We have it. Karen, she just left a couple of months ago to go down south. She had it. Lynette, who works on the 7 Newman, 7 Foster side, she has it. So that's kind of where we're going. I think our LTAC dietitians are thinking about doing it. So too, since they see a lot of nutrition support. But so we take that every 5 years to stay up to date on that, and all about tube feeding TPNs, like I said. Give you 250 questions to do in 4 hours, all about tube feeding TPN. So you gotta kind of get moving. You gotta know your stuff or not. So just to give you a little bit about my background, I did my undergrad at Michigan State. And then I went to Brigham and Women's Hospital in Boston to do my internship. And I had a good experience there. That was like a full year one. Usually most of the internships are 6 months to a year. 6 months usually the smallest. A year if you want to get extra experience or whatever. So I did that. And I came back here, worked in a nursing home for like a year and a half before I got the job at Sparrow, and I've been here for like 21 years ever since. And working, I think I've been in the ICU for probably 15 and plus of those years, critical care. So, and then had my CNSC, I think for 15 plus years too. That's 15 or so years. So that's just kind of my background. I'm here to help answer questions. You guys, I know sometimes come through intensive care units and stuff. So feel free to pick myself or Amy's, or Hannah took over for Karen. She's an NCU too, if you run into any of them. We're always here to help out and answer. So just a quick other background. On weekdays, there's usually 10 RDs here in the adult world and 1 diet tech, like 8 adults, 2 pediatrics. On the weekends, there's only 2 RDs and 1 tech. So just for consult reasons, if it's something that you need right away, that's more urgent, like you want a tube feed or TPN, maybe mention that in the comments. or if it's a Sunday afternoon or morning and it's like, hey, this person is okay to wait till Monday to, to get your full staff in to see because it's just poor PO or something, that might be helpful to help us prioritize things if it's super busy. Some weekends, you get doable, and sometimes it's like way more and we'd have to push some stuff aside. So it just helps us prioritize. There's only 2 of us here on the weekend. We're just doing consults on the weekend. We're doing follow-ups and everything during the weekday. And then I had mentioned the specialties. So we have dietitians who are specialized in nutrition support, the CNSC. We have pediatrics, there's oncology, weight loss, diabetes. There's a bunch of other ones, but those are the main ones I think we have here at Sparrow. I think weight loss, bariatric surgery type of thing is the one. So there's lots of different specialties, or, if you, as you guys are going into certain things or studying certain things, that we have lots of good resources for the dietitians here that can help you out if needed. So we see, when we get a consult, we see them within 24 hours. If it's a weekend, like I was kind of saying, it can wait till Monday, let us know. We'll follow tube feeding and TPN patients. Usually we don't necessarily need a consult for them. We get a list and we'll start seeing them automatically, but it's good if we know that that we're on board and kind of following along. And we usually will follow up on our tube feeding or TPN patients every 1 to 3 days initially until they're stable. Or if it's not even a tube feeding or TPN patient, just somebody who's nutritionally concerning, we may follow up with them every few days. And then once they're stable, it might be more like 3 to 7 days range. We'll follow up with them. So always look for our notes, under the nutrition tab, and we may already have recommendations for you. If it saves us a consult or save you more time, it might just be reading the bottom of our note or something to get a recommendation. It might be right there all along. And then we may also get consults from RN, the nurses too. So some of them come from their nutritional screening. Now, a JACO requirement is every single patient in the hospital screened for nutritional risk within 24 hours of admission. So obviously we can't run around and see that. So there's a set of questions that nurses ask, and then if they trigger so many of them, then they send us a consult. Basically weight loss, how your poor intake, then obviously if you were TPN or tube feeding at home, that should be automatic, but things like that, that if they trigger them, then they'll send us a consult to see them. And then if we don't get any of those consults and the patient's still here at day 7, we try to screen most patients by day 7 if there's no consult. So we may just look at them and see, hey, have there been things that have been missed and things like that. But hopefully between the nurse or the physicians, we would have gotten consulted if it was really that concerning before day 7. All right. So any questions so far before we get into tube feedings and stuff? I don't know if you guys had any questions. No? Okay. So tube feedings, why would we have people with tube feedings? You're probably going to be somebody with prolonged NPO or inadequate oral intake, but you have a functioning GI. Obviously, you see people with severe dysphagia, maybe poor appetite and conditions that require increased nutritional needs, wounds, multiple traumas, major surgery, burns. So you could have somebody who's actually eating, but they're barely eating, eating 600-700 calories a day, but they're requiring 2,000 calories a day. So they keep that up over time. They're not going to heal, not going to get better, maybe lose weight and things like that. So which kind of brings us to our next thing, which is malnutrition. Malnutrition be another one with inadequate nutritional intake. And that's probably the big one too that we probably see, and they say in the literature that supposedly malnutrition is one of the most misdiagnoses out there, and it can be pretty reimbursable too. So what I did is I kind of just went over some quick criteria, what we use to diagnose our malnutrition, because it's a little different. I know some of the codes and stuff, ICD-9 or 10, I think it is now codes. Sometimes they talk about albumin and all that stuff, but that's really not an indicator of malnutrition, at least from our end. So usually we're looking at PO intake, weight loss, and then fat or muscle losses by like physical exam. So here I just kind of said like less than 50% of your energy intake for greater than 5 days can be severe acute malnutrition. And usually you need more than one of these. So one criteria doesn't make it that, but that could be one. Less than 75% of energy needs for greater than 7 days for mild to moderate. So we all know patients who probably barely eaten much for 5 or 7 days. So right there, you're potentially looking at moderate or moderate, malnutrition just with that. And then you need some other factors, weight loss or fat or muscle losses. But, so just think about when they're not eating very well, it can kind of get started, the ball rolling pretty quickly. If you're talking more chronic malnutrition, if it's less than 75% of your needs for greater than 1 month, or less than 75% for even less than 1 month, can be mild or moderate malnutrition. So just your energy intake by itself can be a big, sometimes that's kind of hard to justify without calorie counts, but with 75%, if somebody says they're barely eating much at all, then obviously they're not close to their 75%. So that one at least makes it easier. Weight loss is another one. So the more higher percentage weight loss you lose, depending on how over so much length of time, is going to get you malnutrition, whether it be acute or moderate. So I won't go too much into detail with these, but you can kind of see probably the one we get like for severe malnutrition, chronic malnutrition, like 10% in 6 months, 7.5% in 3 months. We can see those pretty quickly. You have somebody who's 150 pounds and they drop down to 120 in a couple months, they're going to definitely hit that criteria there. And obviously, it's unintentional weight loss and things like that. You're probably sick, probably having other medical conditions going on too. So poor PO and weight loss, usually we need at least 2 of these criteria to be able to say they're malnourished. So it could be PO intake and weight loss. It could be PO intake and fat or muscle losses. So we do fat and muscles. We do a nutrition focused physical exam where we're looking at the temporal regions, clavicles, shoulders, triceps, maybe things like that for signs of, and then your lower legs, calves and things like that for signs and symptoms of muscle and fat losses. And so depending on how severe these 3 things are, then you can diagnose somebody with this moderate or mild to moderate or severe malnutrition. So we just need two criteria usually to do that. So sometimes, like I said, somebody could be eating poor, but they have ascites, so their weight's actually up. So it's kind of hard to tell that they have weight loss, but then you look at them and their temporal, is really sunken in. Their clavicles are sticking out. You can see, your shoulders all rounded and pointy on the upper body. So, they've had lots of losses there. So that may be a telltale sign, or other edemas in their lower legs. I think there was a patient a year ago or so, we used to say just by looking at their height and weight, I think they were like 5'6", 200 pounds. They would fall in the obese category, but they were severely malnourished. And all their weight was pretty much in their lower extremities. They had severe edema. But from the waist up, they were pretty cachectic, pretty much skin and bones. So without even going in the room, you think, oh, they're obese, but you go in the room and then you just kind of look at the patient. They were very cachectic and things like that. So that's some of those criteria that we use to help diagnose the malnutrition. So then, we need tube feedings. So you get tube feedings. What kind of tube feedings are there? We tend to put people on continuous tube feedings, especially in critical care, just because it makes it easier with everything else going on to keep it continuous. Sometimes on the floor it's easier, but as they get home, then you have to consider, well, do you transition to bolus feedings if it's going to be a PEG and long-term thing, which probably makes life easier at home. Not being hooked up to machines all the time, or do you just do nocturnal tube feedings? So they don't have to be hooked up during the day, or maybe it's somebody who eats but still needs some tube feeding. So maybe you give them nocturnal tube feedings at night and allow them to have their appetite during the day. So those are some different things to think about as you do that. And then I don't know if you want to talk about, let's see. So all feeding tubes need to have place. So basically our new tube feeding policy and procedures just came out earlier this month. Mm-hmm. So I'll talk about some of these, but so all feeding tubes have to have placement verified and documented by radiology before giving medications or enteral nutrition through them now. So technically the nurses shouldn't be asking you when the x-ray comes, is it okay to feed or use for medication? It should be radiology verified. So they're supposed to have a statement in there when they read x-rays, it says, tube isn't an appropriate location to administer medication and tube feedings.
Can I have a just quick comment, Ken?
Yep, go ahead.
The way it is right now is if we put a nursing communication order saying okay to use tube feeds or like whatever, okay to use the NG tube, it's okay to use it. So that's not the case anymore. It has to be radiology.
Yeah, it should be radiology. I mean, you may still need to put that in after radiology says it, but radiology should be the one that is the
okay.
Yeah, I kind of joked with Dr. O'Brien the other day and saying that he can't even read the x-rays anymore and stuff. So technically, so it's supposed to be radiology. This was a group there was a few sentinel events here over the past couple of years where tubes were misread and stuff. So this is kind of maybe a little overkill on the other end, but that's how it came about, is because we had some sentinel events, and so they want radiology to be the ones that, and just go from there. And so as we go through the order set, you'll see here, there's a button now when you go into the tube feeding order set, at least, that we have to click that says, yes, radiology verified it. And you can't sign the tube feeding order set, tube feeding orders unless you click that yes button. So if you hit no, it won't let you sign it. So it's basically kind of just, it's a few extra steps or, some things to jump through, but overall, I guess it's the safety. So, and we just had a meeting this morning. So I had asked this question about patients who come in with PEGs or J tubes from, from home or another facility. And they're recommended to be getting radiology confirmation of their tube, even if they were using it just to be safe. It's more or less to err on the side of caution.
Can I just ask a quick question about that specifically?
Yeah, go ahead.
I know on like night shifts and stuff, sometimes it takes a while for the read to get back. Are we implying that we have to wait for the x-ray to be resulted before we can use like an NG tube or a central line or something?
Well, this is specifically to the enteral type feedings, the NGs and stuff, OGs. But yes, it's recommended for the medications to wait as well, unless it's something emergent, like it was charcoal or something. They know that, you're gonna just use old-fashioned techniques and get that in if you need to. But it's recommended, that to do that. And I think it's supposed to be stat in there in the order set for them to read it. That was my impression that they did. I didn't double check since I don't really actually do the radiology part of it, but I'll look at the results, but I don't do the orders. But that was the understanding, is that you would do that because one of the sentinel events is somebody got, they needed potassium phosphate replaced or something, and they ended up doing it before it got verified, and they were giving it into their lungs. So, or some type of replacement they were giving real quick, and they ended up giving it into their lungs, and this was only like a few months ago that one happened. So they're recommending it even for medications to wait as well. So yeah, it may be a little bit longer, but hopefully as radiology, as we're putting more on them, that they're supposed to have smart phrases and stuff. So hopefully as they look at it and get used to it, they'll be more responsive to using the wording and getting that back to us in a more timely manner too. The other big part of the policy and procedures is that we no longer routinely check gastric residuals. So for nursing, they probably like that. They're not going to check residuals. If you want to check residuals, or you feel patients having, abdominal symptoms or something like that, or maybe they threw up a little bit, and then you just want to check them for a day to make sure, then the upper allowable limit it's recommended that you use 500 mLs as your limit. So right now it was 300.
For this, because there's no kind of data to support the usual use, especially at least in the ICU, right? Because I was talking once to Amy about it, and she told me that you guys were working on changing the policy. Because from data standpoint, if the patient is asymptomatic, the residual does not change anything. Is that correct?
Correct. Yeah. So that's basically what the literature is saying, is that there's no increased risk of aspiration or adverse events by checking residuals, and you probably hinder patients from getting their full nutrition, which probably in the long run keeps them from, in a negative nutritional balance over the course of their stay here if we keep checking residuals and maybe holding inappropriately. So, but if you do need to check a residual, then it's recommended that it's 500, and that's in the order set. The wording, like if you were needed to go back and look at it when the order set's put in under the NG or OG, whatever it is, the PEG that's listed, those wordings are there. It's like residuals are no longer checked, but if you need to, 500 is recommended. So at least you'll have, if you need that as a reference guide, it should be there for you. And then let's just say a patient did have, let's say you did check residuals and they had 600 residual. Mm-hmm. The nursing should be putting 500 back, and then they would just discard 100. Okay. So that's also in all that wording underneath there too, is if you did check them and you had more than the 500, you would give 500 back and then discard the rest. So you wouldn't want to discard the whole 600, because then there goes a whole bunch of nutrition and maybe meds and things like that out the door. So that's all in all the wording and everything's in the order set. So it should be there if you need to reference that. But probably the big thing is the gastric residual. So the nurses, they took a course, they had LMS training on all of this. So they were pretty much done with that. This order set kind of got delayed. It was supposed to come out in November, and then with things going on, the increased spike in COVID, it got pushed back to January, but they pretty much had all been educated in November. So they were all aware of it coming in. Now let's see if I get this here. Oops. I think I'll just go. Let me just see here. I have this. So I have I think I have this. So this was one of the tips and tricks that came out from the tube feeding group that put this together. Let me see if I can get this to load. Taking a while. But basically it kind of goes through. If not, we can just jump ahead. There it is. There. You guys see that okay? Or not?
No.
Let me see. Okay, I have to go back to my share screen. New share. I think I have to do, there we go. There we go. You see it now?
Yes.
Okay, good. All right. So basically this was just improved safety for enteral feeding. So it kind of goes through the things. So basically when you go into the tube feeding order set now and open it up, whether it be the adult or the critical care, there's these three sections now. So if you were to place a feeding tube, you could hit the place and verify, and then that will bring up all this stuff where it talks about placing the feeding tube. It'll get you the x-ray, and then it'll consult us all in one. And that's one section. So you could sign that, and all those things would go into effect if you needed to do that. The next section is the feed monitor. This is where you put the actual orders in. Let me see. So we as the dietitians, if you want, we tend to do this section the most, put your formula and your goal rate in. But if you guys needed to do it, or it was after hours, we weren't here. Basically, when you go back and hit on this feed and monitor section, let's go back here. So that one right there, you're going to, the first thing that pops up is this radiology thing. And that what we talked about, have you verified that radiology is confirmed placement? So hopefully you can hit yes if it's already been done. If it's been no, because maybe the order just came through and we started, or we were on rounds or something, said, hey, let's start it, but the x-ray hasn't been, nurse hasn't been able to place the valve off and the x-ray hasn't been able to get done. Then you'd probably have to hit, no. And then you'd go through and do all your other orders. So if you hit yes, you can go through and sign the actual order. If you have to hit no, you're unable to sign the actual order, so we would have to pend it. So afterwards, we would have to go in and reopen that order up, verify, then you would have to hit yes for the radiologist, and then you could sign it. So that's the only thing that's one of the issues we're having right now, is that sometimes there's a delay because we're not able to go, maybe it's after hours and people aren't able to go back in and click yes, it's been verified now finally, and then start the tube feeding. So sometimes things are getting delayed. So
hey, can I ask a quick question? I'm sorry.
Go ahead.
So with this order set, let's say I'm on days, and then I have to pend it because the radiologist hasn't read it, and then the night team is when the radiologist reads it. Is it possible that the night team can go ahead and sign my order for me?
Yeah, it should be, yeah.
Okay.
It would just be, as long as they, yeah, if they're able to get in and do it, then yeah, that would be great. I was gonna go through and show you guys how to do it, or what you might need to, because one of the things is it doesn't pop up when you go back into the pending order. You kind of have to find that perform tube feeding section and click on the yes for the radiology. So part of this is what I kind of did. Sorry about this isn't perfect. So this is what we were talking about before. You guys back on the PowerPoint, right? You guys can see that?
Yes.
Okay. So there's the perform tube feeding. Some of these are kind of pictures. So this is the actual order form that comes up just to kind of show you. Usually if it's the adult order form on the floor, which I think you guys see a lot too, you're going to pick the tube feeding and NPO panel if they're NPO, or tube feeding and oral diet, one of those. And then when you click on one of those two boxes, if you need to, if we haven't done it, then it gives you your formula choice and rate and all that stuff you can fill out there if you need to. But hopefully we would have already filled that out for you, and you're just going to need to verify the placement. So if that's the case, if it's already verified, you know, you're going to have your pending orders here on the side. You could just click on that. And then probably the main thing we see, you know, make sure you say manage this unassigned work. Probably the thing we get, people either maybe get frustrated, or they, you know, maybe they accidentally hit delete, then they all go away, and then you got to start from scratch. If you can hit the manage unassigned work, and then the way the order set's done, the perform tube feeding you see down here on the bottom always ends up on the bottom for some reason. So at least it makes it easy to find. It's always going to be on the bottom, and then you just have to click that perform tube feeding title there, and then it brings up your radiology thing, and then you could click yes if that's been done, if you would need to, and then it should allow you to sign it. So that's the only thing. That's the only issue. We're trying to get them to see if they can't make it this. You know, when we hit manage this unassigned work, if it couldn't pop up like it does when we initially do it, to make it easier to find and verify the placement, but you just have to do an extra step and click on that perform tube feeding, and then that pops up, and then you can hit yes for the radiology, and then it should allow you to sign it from there. So does that kind of make sense for everybody, or help out a little bit?
Mm-hmm.
Okay. Any tube feeding type questions? I think that was next thing I was going to talk about was PN a little bit. I don't know if there's any tube feeding questions you guys have about things you've run into or anything that I could answer, or types of tubes or anything like that, formulas.
I mean, at least, like, let's say overnight when you guys are not there, or the weekends, and we want to start kind of a basic tube feed order, isn't it? That's, I believe, because I've tried it once and I think it works within the order. So would you have kind of slides to show them like what are the basic kind of like tube feed bags that they can use, especially to start on out overnight?
Yeah. If you critical care, the critical care order set has one that's
care, yes.
pre
Not talking about the
out.
The critical care.
Yeah, the critical care one. Let me go back here. So this is even though this isn't the critical care one, this is somewhat the critical care one will come up with its Peptamen BHP is kind of our standard go-to. So we'll say that there, and then they'll say 10 there. So that comes out pre-filled out. So if you needed to start a tubing overnight or something when we weren't here, you could open that order set and basically verify the placement with the radiology is going to be the new thing, and then pretty much just sign it.
Okay.
And then that would get it going at 10 an hour, and then we would trigger us a consult, so we'd come by the next day, and then, you know, either if that's a good formula, give you the goal rate, or we'll switch it to whatever we need to. But we've pretty much the nutrition advisory committee that has like Dr. O'Brien on it, Dr. Mosier, a few nurses, myself, we kind of determined that's a good safe formula to start with. So we've that's kind of why that's there, especially in critical care, because sometimes you know we don't want to wait 12 to plus hours to get it started sometimes.
Correct. Okay. Perfect.
So that's there.
We use this for floor patients also.
What's that? Sorry.
Pharmacy will approve this for patients on floor also, not in the ICU. Can you hear me?
Well, pharmacy wouldn't have it. Yes, I can hear you.
Yeah.
Pharmacy wouldn't have anything to do with tube feedings. They would only do TPN.
So we can use
So, yeah.
the same order set for the patients on the floor and not in the ICU as
well. You probably
sometimes
could.
because I
probably
was in this similar situation. I think it was meant to be started and not started, and they really wanted to start it overnight. And I think I had to make a couple of calls to understand, to find out the standard, something which we can use. But yeah, I was hoping if I'm in a similar situation later, I can probably use this. I think it should be okay.
But the other thing would be, I mean, did we put a note in maybe and just the order set didn't get filled out? So maybe it's just looking at our note. You can just plug in, like here, you just click on this thing and it lists all the formulas we have. And then we click it, you know, and click on that one that they recommended and fill in the numbers too. So that could be another option if it was there.
Yeah. And another question I had was with patients with renal disease and this borderline hyperkalemia. Will like that change? I know TPN, of course, has some special formulation, and
yeah,
also,
I mean,
do we need to make?
Well, we have a formula that's lower in potassium, a renal formula, so it's pretty. It's like I think 24. It's like 20 milliequivalents per liter versus like 40 some for most of the other ones. So it's quite a bit less. And plus that formula is concentrated, so a whole liter of that's like 2,000 calories, where the other ones would be lower. So we look at that, but if it depends on if somebody's on dialysis, is it a one-time thing? But yeah, we definitely can do that sometimes. Yep, and use that formula if we need to.
Sounds good. Thank you.
Yep. So any other questions over here? Okay, I'll go to the next. We always come back to. Let's see. Let's go. Oop. All right. Let's see if we get that. Okay. So PN or TPN and things like that. So basically, I was kind of going through like what do we need to have TPN? Usually, you see a lot of our patients that do tube feedings. I would say most of the time in the hospital, there's 3 to 5 adults on TPN at a given day. So that not very many. So I think we do a pretty good job of getting patients tube feeding that can get tube feeding. And I think some of it may keep them from going to TPN, from not using their gut. But when you do need TPN, you know, it's a good thing to have. So what constitutes needing TPN? Maybe a prolonged major upper GI bleed, severe bowel obstruction, severe and protracted ileus, intractable nausea and vomiting, you know, vomiting, diarrhea that aren't improving with therapies, high output GI fistulas. And then, but even with that, the GI fistula, depending on where it is, you may be able to, if it's high up, higher in the GI, you may be able to feed below it, and then GI ischemia. So those are some of the Aspen kind of guidelines of American Society of Parenteral and Enteral Nutrition as to why you would need parenteral nutrition. So usually you don't see like anything like poor PO or anything like that in there. Contraindications for PN, it is a super hyperosmolar kind of solution. So if it's somebody who couldn't handle that, you wouldn't want to give them that. Like a lot of your TPNs are like 1,600 milliosmoles of solution and stuff like that. So you probably wouldn't want to do that. Severe hyperglycemia, like our Clinomix is 20% dextrose. So it's pretty high concentrated dextrose and things like that. So just be aware of that they're going to get it. And that's the Clinomix is the only thing we have right now, and it's pre-made. So there's nothing we can do to change that. If there's severe electrolyte abnormalities, you may not, like I said, the Clinomix comes pre-made, so we can't necessarily adjust that. So if you're trying to get no potassium in there, just know there's going to be some in there because of the Clinomix. Or if you want to give extra, you won't be able to give extra in that TPN. You'd have to give it outside. Volume overload, you know, you're given 2 liters of TPN to get about 2,000 calories or so. So can the patient handle that? You know, depending on their CHF is really that bad or EF is bad. And then, or if they're trying to give PPN, we'll talk about that. You're not going to give much nutrition. You're going to give lots of volume without much nutrition. So is it worth it? Inadequate attempts to feed enterally. Have you even tried to feed them enterally? Or tried enteral access and things like that? Make sure we've tried that enough before just jumping into TPN. And then sepsis is a relative contraindication just because PN may exacerbate that, and obviously TPN may could lead to fungal infections and stuff like that with the lines. So PPN, or peripheral parenteral nutrition, usually we don't, most people like in critical care have central lines, so it's not an issue, but sometimes on the floor, they're thinking about PPN for patients and things like that. So you're limited by volume and time. So 2 liters of our Clinomix solution here only gives 680 calories and 85 grams of amino acids, plus whatever lipids you might order on top of that, because that comes separate. So, I mean, for 2 liters of volume, you're getting 680 calories. So you guys should just have to weigh that as a physician. Is that worth it? Nutritionally and volume-wise, is the patient able to handle that? And then usually you can only use that line for 5 days or so with the PPN. Either you need to switch the line, or hopefully, you'd probably change the TPN in a central line if they really did need peripheral, parenteral nutrition for longer than 5 days. But you could, the vein may not, may ruin the vein if you go much more than 5 days using that vein for PPN or peripheral. Where if you look at TPN, 2 liters of the Clinomix central solution provides 1,600 to 1,760 calories and 100 to 260 grams of amino acid plus lipids. So you can get quite a bit more having that central access. So just to show you the comparisons. And part of this is we just came out, pharmacy just this week came out with a new Clinomix solution that's probably more going to be for critical care or patients on the floor who have high protein needs, maybe with wounds and things like that. So it's a lot higher in amino acid content than the other ones, as you can see. So that's the one that's lower calories, 1,600 calories, but you get 160 grams of amino acids for 2 liters of that versus the current one we have, which is about 1,760 calories, but only 100 grams of amino acid. So you have a little different option just if you have the patient with higher protein needs. And that just came out this week. So, or it started being available. We got it in. So, and it's also generally considered that you should provide PN for at least 5 days to receive benefits of it. So there had been some studies in the past that show, if you're going to start PN and only give it for 2 days, then you shouldn't start it at all. So, I mean, the anticipation should be that you would need it for at least 5 days to be able to get the benefit of it and not give risks to the patient for infections and things like that. Now, obviously, sometimes you don't always know that going ahead of time. Maybe they miraculously, their GI gets better or something like that, then, okay. But if you know that you would only do it for a few days, or your plan is only to do it for a few days, then it's probably not worth it in the end. So here I just kind of did the order set here. I have these under my favorites, but it'd be under TPN. So I'm just going to kind of go over the order set with you real quick for this one, just to show you. And then this is at the bottom of the order set. You'll open it up and they'll give you labs and things to do. And then at the bottom is pretty much where the actual nutrition part of it is in these 4 things. So the peripheral is down here, central is here, and then with lipids or without lipids. And so you'd click on one of those 4 purple bars, and then it would kind of bring this up. And then you'd have your Clinomix here. And then basically you're picking 1 liter, 1,500 mLs, or 2 liters. So in this instance, I picked the 1,500 mLs, and it kind of shows you what it would give. And then it'll ask you, if you pick with lipids, then I'll ask you what lipids you want to. Let me see here. And then here would be the same thing if you did saved work. And then you'd manage this unassigned work, because a lot of times sometimes we'll pend it for you, because PN we cannot sign for because it's a medication, but 2 feedings we can. So we would pen the TPN for you. You'd click on that, manage this unassigned work, and then you could just sign it after you did that. So for 2 feeding TPN orders, just remember 2 feeding orders can only need to be changed as needed. So once the 2 feeding order is in, it's going to stay the same until you change it. And then dietitians can help order and help manage those orders. We have order rating privileges in the hospital to do that. So we'll usually do that for you, unless you want to do that. PN orders, we're more than happy to help you. They need to be renewed or adjusted daily because it's considered a medication. So we can help you and pen the orders if needed, but we can't sign for them. because it's considered a medication. So since we're not allowed to sign for medications, but we'll be happy to help you do that. And then hopefully we get to the place where they're nice, there's, you know, daily TPN where it doesn't need to be adjusted, or their goal. And then you just have to hit renew every day going forward for that. So if they were to stay on the TPN, it would make it nice and easy. So that's pretty much what I had for that. Feel free to answer any other questions you have. Does anybody have any questions about the TPN or anything else?